Good evening to everyone. Today we are going to talk about two topics. One is about toxicology, which is basically going to be on how to differentiate between neuroleptic meridian syndrome and serotonin syndrome, which is actually two things that we do see in the emergency department, but is actually very difficult to differentiate. And second thing is something about staph aureus bacteremia, which is a little bit going into critical care rather than emergency medicine. But I found it interesting, so I thought I'd share a little bit about that as well. So, getting into the topic, coming to NMS, it is basically a complication of antipsychotic medication, specifically D2 blockers. And it is more common in males. Why is it more common in males? It is postulated that it is more common because males tend to have these disorders a bit more commonly, and they tend to be receiving a little bit higher doses of these medications than females on average. And that is probably why they are a little bit more prone for this. There is no particular genetic sorry, gender predisposition as such. So it's basically because they are getting higher doses of antipsychotics. Usually, this happens within therapeutic range of this medication. It's not an overdose problem. It is something that happens within the therapeutic range, and but the risk of this thing will increase when you go into the higher levels of the medication. So once you get into the higher power, ceiling of the drug, then the risk of NMS increases. Why this is an important topic to be aware of is because the mortality rate is around 10%. And if you remember, the mortality rate of an inferior volemia is around 4%. So this is about more than twice as dangerous as an inferior volemia. So this is definitely something that you have to be aware of. So the pathophysiology is basically due to D2 blockade, and this has different effects at different levels of the brain. D2 blockade and the nigrostriatal pathway will lead to Parkinson's-like symptoms, and this is basically a type of acute Parkinson's-like phenomenon. So that is a basic simplification of what NMS is. Dopamine deficiency in the hypothalamus will lead to autonomic symptoms. Dopamine alterations in the reticular activity system will lead to alterations in sensorium, leading to coma and all. So these are the main things. You can also have the problem with excessive muscle tone and dysautonomia, hyperthermia. All of these things will lead to a risk of rhabdomyolysis. And actually, this is the main reason why patients will have increased mortality, the rhabdomyolysis and the hyperthermia. So these are the important thing that we actually have to try and treat. So coming to the causative drugs, basically is going to be your antipsychotic, both your atypical and typical and antipsychotic. Generally, the first generations are a bit more notorious for causing this. And usually it happens within a month of initiation treatment. But the caveat is that even patients who are on these medications chronically may develop an NMS. So that is something that you have to keep in mind, that even if the patient was on this for a long time, they could still develop an NMS. Then some antiemetics which block the dopamine receptors, like chlorpromazine, metoclopramide, promethazine, these can also lead to NMS, so, or at least make things worse. And withdrawal of dopamine agonists, like in Parkinson, if you abruptly stop them, then that is also a risk factor for developing NMS. So risk factors are like we mentioned, and also if you are rapidly escalating the drug doses, using parental routes for the drugs, multiple antipsychotics being used, co-administration with lithium, all of these things will increase the risk of NMS. And there's also a family history and personal history of NMS that also increases the risk. Clinical features, this is very important. So onset is very gradual compared to serotonin syndrome. So this is one of the big differentiating factors. Yeah, it is usually over 1 to 3 days, but it can also occur over weeks sometimes. And resolution is also slow. Resolution will take around 2 weeks. In contrast with serotonin syndrome, where on stopping the serotonergic drugs, usually the symptoms will resolve within 24 hours. There is a classical tetrad for NMS, and this is a combination of altered sensorium, fever, muscle rigidity, and dysautonomia. So this is the classical tetrad of NMS, and if you look at the diagnostic criteria, these are what basically forms your the major criteria. And there is a classical order of symptoms also. So first comes the altered sensorium, then comes the rigidity, then the hyperthermia, and finally the autonomic instability. So it might not be that you will see all of them at the same time, depending on when the patient actually presents to you, when in terms of the disease course. I mean, so that is one thing. But again, this is not a hard and fast rule. It's not like it will only occur in this particular order. Complications are what will actually kill the patient. So this is what actually leads to the mortality. We have aspiration pneumonia, and if you know about heat stroke, the complications are similar. Rhabdomyolysis, renal failure, DIC, all very similar to heat stroke. You can also have risk of venous thromboembolism and cardiomyopathy. So basically, very similar to heat stroke. So diagnostic criteria, there are no perfect diagnostic criteria, and the diagnosis is very difficult in real life. But these criteria do give you some idea about what you're actually supposed to look for. So there are some major criteria, the minor criteria, some exclusionary criteria. So the major criteria are what we mentioned in the tetrad. So fever, they have defined as more than 38 degrees Celsius on two separate occasions, measured oral temperature. And then you have lead pipe rigidity. This is the classical rigidity in NMS. So it's lead pipe rigidity. Some patients who have some degree of tremor, they might present with the cogwheel type of rigidity also, but there is classical type of rigidity in NMS is the lead pipe rigidity. There can be psychomotor slowing, so patient might appear a bit slow, or it can worsen to coma later on. So it's all of this is sounding very similar to Parkinson's with fever basically. Then sympathetic system lability will come to what that means, and recent dopamine antagonist with exposure or agonist withdrawal. So this within 72 hours. That is what recent. So what do you mean by sympathetic nervous system lability? So they have defined it as four things. One, uh, and you should have any two of these. So you have increased BP, that is around 25% more over the baseline. That is either your systolic or diastolic. BP fluctuation over 24 hours. That is systolic fluctuating by more than 25% over 24 hours, and diastolic fluctuating by more than 20% over 24 hours. So that is what you mean by BP fluctuation. Then you have diaphoresis and urinary retention. So if you to get positive ability, you should have at least two out of these four criteria. Then here minor criteria like elevated creatine kinase more than 4 times upper limit of normal, myoglobinuria, increased heart rate more than around 25%, increased respiratory rate more than around 50%, hypersalivation, tremors, muscle cramps. So these are the minor criteria. Then you have exclusionary criteria because there is no symptom or lab test that is absolutely specific for NMS. So you have to exclude all of the other things that can look very similar to NMS, like any infectious causes like sepsis, meningoencephalitis, any other toxicological causes, metabolic causes, like hypoglycemia and all, or neurological causes like your some brainstem bleed that is leading to hyperthermia and all of those things you will also have to look for and exclude to actually confirm the patient is having NMS. There are points for this criteria that I have not mentioned, but basically it will total to around 100. And if you have more than 74 points, that is considered as positive. But again, there are a lot of caveats to using this criteria, and it's not very well validated compared to something like the Hunter criteria for serotonin syndrome. Coming to the differential diagnosis. So this is going to be similar for both these disorders. So any acute dysautonomia, so serotonin syndrome, malignant hyperthermia. Malignant hyperthermia is something that usually happens with inhalation anesthetics. Not very common in the ED, but sometimes very rarely can happen with succinylcholine also. And malignant calcitonia. Malignant calcitonia is NMS, basically a variation of malignant calcitonia. So it's again very difficult to differentiate between the two of them. Other causes of altered sensorium like tetanus, heat stroke, thyrotoxic causes, symptomatic toxicity, sepsis, meningoencephalitis, all of these things are possible. And so our laboratory workup is basically to be geared towards ruling out all of these causes. So now, first and foremost, you have to do a good neurological examination, measure the core temperature, because temperature control is going to be one of the main things that you'll have to do for these patients. creatine, CBC, LFT, RFT, creatine kinase level, because in the correct clinical context, an elevated creatine kinase is something that will point you towards a diagnosis of NMS. So even though it's a non-specific thing, in the right clinical context, it will point you towards this diagnosis. For ruling out other things, you can will do that the thyroid function test, you evaluate for any sepsis, and depending on the presentation, you might do a CT scan plus or minus an LP. Labs, again, this is something important. So creatine kinase, as we said, is usually elevated more than 1,000, and most of the patient will at least have something more than 300 at least. Leukocytosis can actually be quite significant. So it can be anything from 10,000 to 40,000. So this is quite significant. Again, this is a good example of why the CBC is not a very good thing to actually rule in or rule out infections. And we will come to something else later on today, where we have a big infection which actually presents with leukopenia and not leukocytosis. So again, the CBC is not a very good thing to be actually ruling in or ruling out infections. Myoglobinuria, uh, renal and liver dysfunction, and various types of electrolyte dysfunction, sodium abnormalities, hyperkalemia, hypocalcemia, hypomagnesemia, and metabolic acidosis, and basically multi-organ dysfunction depending on the severity. And now coming to the management. So the management is primarily going to be as supportive. You patients will have some insensible fluid losses. So you'll be wanting to give some IV fluid. If the patient is in the rhabdomyolysis, you'll be wanting to give some IV fluid. Make sure the urine output is good. Good. Urine output is clear. Antipyretics. Some textbooks will tell you that antipyretics should be given for these disorders, and the truth is antipyretics are not very helpful, because the hyperthermia in NMS and serotonin syndrome is not mediated through the hypothalamus. So it is not going to be reduced by giving things like paracetamol. So you'll have to do physical cooling measures. So this is one of the most important things that you'll have to take out from this lecture. Antipyretics are not the solution to fever with these kinds of disorders. Obviously, if the patient was on D2 blocker, then you'll have to stop the causative drug. And if you abruptly stop dopamine agonist, you'll have to restart that. If the patient is having seizure, you can consider something like benzodiazepine, and for agitation, you can consider things like clonidine and dexmedetomidine, so which is something a little bit different to what we usually do for agitation, so which is something special for these disorders, and we'll come to that in a little bit. So there are some specific things that you can give for NMS. One of them is bromocriptine, and which is actually the first line drug for this disorder, if you actually think it is NMS. So it is a dopamine agonist, and there is some data, not very robust data, admittedly, but there is some data that it might reduce mortality in severe NMS. And the starting dose is, as I mentioned in the slide here, I'm not going too much into the dosing. You can refer this later on. And you should actually continue this for 10 days, at least 10 days after the resolution of NMS, and then slowly taper it off. Because if you don't do that, there's a risk of NMS rebounding. So again, this is how you use bromocriptine. The side effects are, it can actually worsen psychosis. It can be a problem because patient will be coming in ultrasensorium, and bromocriptine is something that can actually worsen psychosis, can cause hypotension, can cause vomiting. So these are things that you should keep in mind. And an alternative is amantadine. And in severe and refractory cases of NMS, you can actually consider combining both bromocriptine and amantadine. It also has some dopamine agonist properties. The second line drug is dantrolene, if you have it available. Basically, it is a direct acting muscle relaxant. It will help with things like rigidity and hypothermia. But basically, it is not going to be helping with it is not going to be acting on the pathophysiology directly. So it basically helps with some of the symptoms. So it's not a first line thing, and shouldn't be used as monotherapy. It is contraindicated in patients with liver failure and patients on CCB. So if the patient is having contact arrhythmia, then give CCB, then dantrolene is not appropriate, and can be given IV. And in severe NMS, the final option, which if it is refractory to all therapies, is ECT, and it's particularly useful for patients with certain psychotic underlying disorders like schizophrenia or depression with psychotic features. In these kind of conditions, they are actually going to have a better response to ECT. So this is a last slide thing, and it's definitely not something that you will be you know, ordering by yourself. Obviously, it will be a multidisciplinary decision. But again, this is the last line approach. So in summary, basically, there's no symptom or lab abnormality which is present in 100% of the cases of NMS. So it is a very difficult diagnosis, especially if the patient is having an underlying psychotic disorder, and the underlying sensorium of the patient is actually abnormal. Then the diagnosis becomes very, very difficult. So that those are some things in mind, and that is why the diagnosis of NMS is very tricky. Having talked about NMS, now we are going to shift on to uh, serotonin syndrome. So in serotonin syndrome, the pathophysiology is basically going to be increased serotonin in the CNS, as the basic name suggests. And the common causes are going to be your antidepressants like SSRIs, SNRIs, and some a variety of other drugs like lithium, analgesics like tramadol, fentanyl, and some antibiotics as well like linezolid. So all of these things can cause serotonin syndrome, especially if you have multiple of such drugs being given together. That is usually when this problem occurs. So if you are going into the whole physiology of serotonin, you have seven different classes of these receptors. So you have 5-HT1 all the way up to 5-HT7. And to make things even more complicated, you have further subdivisions within these classes. 5-HT1, for example, 5-HT1A to 5-HT1F. So what are the ones that are actually important in this particular syndrome? So it's basically 5-HT2A and 5-HT1A. 5-HT2A is what actually gives you the severe symptoms like your hyperthermia, increased muscle tone, etc. 5-HT1A contributes to some of the milder symptoms like increased anxiety, hyperactivity, etc. So what is not here is actually 5-HT3, and that will make some sense in the coming slides. So coming to the medications that actually cause this thing, serotonin syndrome. So I've already mentioned the main things: SSRIs, tramadol, TCAs can cause 5-HT3 antagonist. So why do they cause this thing, serotonin syndrome? So we were basically talking about increased serotonin action. So why would a 5-HT3 blocker cause this? Well, it is postulated that blocking the 5-HT3 receptor, which actually could actually lead to increased action at the other receptors like 5-HT1, 1A and 2A. So that can lead to serotonin syndrome. So remember that MS at Howden syndrome can also make things worse. And you have your other antiemetics like metoclopramide, anti-epileptics like valproate, carbamazepine, and some antibiotics like linezolid, even Vishnu's favorite drug, methylene blue, that can also cause this. Then analgesics like tramadol, fentanyl can cause this, and even lithium can also cause this. So what you should keep in mind is that this may develop in the hospital if the patient was admitted for some time, patient with depression or something, patient was admitted for some time with some other issue, they can actually develop serotonin syndrome inside the hospital if due to some drug interactions. So that is something that you have to keep in mind. So So it's basically it's another thing is there can be a role for drugs which are not actually serotonergic drugs, which but can still contribute to this syndrome. How? By inhibiting certain enzymes, they can inhibit the metabolism of some other medications, increasing their levels, leading to serotonin syndrome. And some drugs that can do this include ciprofloxacin, fluconazole. There are multiple drugs. These are some of the ones that we are probably more likely to see in clinical practice. So again, these drugs, even though they are not directly causing a serotonin syndrome, they might indirectly lead to serotonin syndrome. Again, this is why serotonin syndrome might have developed in an already admitted patient. And I've given multiple drug interactions here that can lead to moderate or severe serotonin syndrome. and you can go through them later on. And I would, it's not possible to actually by heart all of these drug interaction. I would recommend you to actually refer some online source in case you are having any doubt about whether the patient's drug current drug regimen could actually lead to serotonin syndrome. So basic clinical features compared to NMS is just a much more acute thing, and usually it resolves much quicker also. So acute also within 20 to 12 to 24 hours, resolution also within 24 hours if the causative medications are adequately, appropriately withdrawn. We had a tetrad with NMS. We have a triad in serotonin syndrome of ordered sensorium, sympathetic hyperactivity, and neuromuscular hyperactivity. So we'll get into what all of these things mean. Neuromuscular hyperactivity, this is actually the key part of the diagnosis. You have hyperreflexia, and this hyperreflexia tends to be more obvious in the lower limbs compared to the upper limbs. It will be there in the upper limbs also, but it will be more prominent in your lower limbs. Clonus, it can be inducible clonus, ocular clonus, or spontaneous clonus. The problem with spontaneous clonus is that it can mimic seizures, and which can make things a lot very confusing. You can have other things like tremors, myoclonus, akathisia. Akathisia is basically the inability to stay still. And in late stages can also progress to rigidity. Not in early stages, late stages can also progress to rigidity. And that is why the differentiation between serotonin syndrome and NMS can become a little bit difficult later. But the key findings are going to be your hyperreflexia and your clonus. And this is why in a patient presenting with what seems to be a drug related toxicity, it is a good idea to check the patient's reflexes, and it is a good idea to actually look for clonus. If you don't look for this, you will actually miss this diagnosis. Mental status changes, agitated delirium, seizures, and coma. So one of the big things that we'll have to do for this patient is actually calm the patient down with some medications, which will come into. And features of sympathetic or hyperactivity like hyperthermia, hypertension, tachycardia, diaphoresis, flushing, mydriasis. And one of the things that can actually help to differentiate this serotonin syndrome from NMS is actually the presence of increased bowel activity in the form of nausea, vomiting, and diarrhea. That is not present in NMS, and that is more seen in serotonin syndrome. So, not in every case, but if it is present, that is a clue that the patient is having serotonin syndrome and not NMS. And the GH symptoms can actually be a prodrome to the other findings also. So again, we are just re-emphasizing the difference between the two. Serotonin syndrome abrupt, NMS gradual. Serotonin syndrome rapidly resolving, NMS gradually resolving 2 weeks. Neuromuscular findings, tremors, clonus, hyperreflexia, and serotonin syndrome. NMS, diffuse rigidity. Reflexes are increased in serotonin syndrome. They are more likely to be decreased in NMS. Pupils will can have mydriasis in serotonin syndrome, and in NMS it will be usually normal. And you'll be having a feeling that serotonin syndrome basically sounds a lot like sympathomimetic syndrome, and you'll be very correct in that observation, because these two things are basically the same almost, and impossible to differentiate. So the serotonin syndrome is basically going to look exactly like sympathomimetic overdose, except for the neuromuscular findings. So this is the same thing that I've mentioned here. Coming to the differential, so other toxidromes, sympathetic mimetic overdose is going to be almost impossible to differentiate at times. Alcohol, benzodiazepine, barbiturate withdrawal, anticholinergic toxicity. In there, we'll have decreased sweating and hyperthermia. So compared to here, baclofen withdrawal, all of these things can lead to can be very similar to serotonin syndrome. Other hypothermia syndromes, NMS, malignant hypothermia, heat stroke, brain stroke, leading to hypothermia, thyrotoxicosis. Again, these things that we should always keep in the differential and rule out as well. And of course, sepsis, because if the patient is coming with altered sensorium, fever, sepsis is also always going to be on the differential, and you're always going to have to rule out things like sepsis and meningitis. Lab abnormalities are going to be almost very similar to NMS. So leukocytosis, lactic acidosis, elevated CKDIC, renal failure, liver dysfunction, and electrolyte abnormalities, very similar to NMS. Coming to the criteria, we have something called Hunter's criteria. So Hunter's criteria is actually quite simple. So it is like you should have any one. If you have any one, then the diagnosis is present. So, but you have basically five options. Number one option is spontaneous clonus. If you patient has spontaneous clonus, patient is having serotonin syndrome. Second thing is patient is having inducible or ocular clonus with agitation or diaphoresis. If the patient is having that, the patient is having serotonin syndrome. So either inducible or ocular clonus with agitation or diaphoresis, patient is having serotonin syndrome. Sometimes you can have a combination of only tremor and hyperreflexes. So if the patient is having very severe tremor, then clonus might be very difficult to actually elicit. So that is why tremor and hyperreflexia have been by itself can also be diagnosed. And finally, combination of hypertonia, hyperthermia, and inducible or ocular clonus. So what should you take away from this? The center of the diagnosis is what? Clonus. Almost always clonus, except in conditions where you have severe tremor and you are not actually able to properly assess for clonus. Clonus, the Hunter's criteria is focuses almost always on clonus. And the sensitivity is around 84%. So why very mild early cases of serotonin syndrome you can actually miss uh, based with this criteria, but it is actually quite specific, 97% specific. So this is the same thing, but only thing is shown in algorithmic form. This is taken from the IBCC, and here you can see serotonin syndrome. And what some people say is that if you actually need a reflex hammer to elicit the reflexes, that's probably not serotonin syndrome. You don't you can actually it is like patient is having such exaggerated reflexes that you can actually elicit with your hands, and you can also see the ankle clonus being demonstrated here. Again, if you don't actually look for angle clonus in these patients, you'll actually miss the diagnosis. And another caveat is that if the patient is having some chronic neurological disorder for some reason, obviously the diagnosis becomes a lot trickier because these findings may be present because of that. So coming to the goals of treating serotonin syndrome, there are basically two main goals in serotonin syndrome. One is you have to treat the hyperthermia, because what actually kills the patient is going to be the hyperthermia. Hyperthermia will lead to seizures. Seizures will lead to decrease decrease oxidation, hypoxia, can lead to aspiration, all of these things, and it will eventually lead to death. So that is one thing. Second thing is to treat the agitation, because agitation can also lead to things that eventually lead to things like rhabdomyolysis. So these are the two basic goals when you are actually trying to treat this disorder. The special drug for this thing is cyproheptadine, and uh, it is a first generation antihistamine with some anti-serotonin activity. So what is the problem with this? It is only available in oral form. So if you have a patient with having severe symptoms, the an oral medication might not be a great option, but it can be given to the NG2 method. It's best for mild cases only. So it's not something that is going to actually rapidly reverse the patient with severe serotonin syndrome. So there are some contraindications. Basically, if it can cause some anticholinergic side effects. So bladder obstruction and narrow angle glaucoma, it's actually contraindicated. And obviously, like most first generation antihistamines to cause some sedation and all. It's actually what you would actually want in the patient with some anxiety. So this is the dosing. It can be given via the RELS tube. Now coming to dexmedetomidine. The interesting thing about dexmedetomidine is that it has some role in actually counteracting the pathophysiology in serotonin syndrome. How is that? It can stimulate the alpha 2C receptors in the striatum, leading to actually some modulation of your serotonin levels. So it can actually reduce serotonin levels somewhat. And it can also stimulate the alpha 2A receptors in the brain, and leading to some sedation and reduce sympathetic tone. So in this way, this is a sedative that actually helps to actually counteract the pathophysiology of serotonin syndrome, and that is why it might be better to prefer this over benzodiazepines. And there are other reasons also. So Dex, it will not suppress your respiratory drive. So uh, it is a bit safer in that regard compared to something like Midas and all. It can be titrated. You have to basically you have to chart an infusion of this, and so you can titrate it to effect. So it's a little bit more easier to control compared to bolus dosing of Midas. With benzodiazepine, there's some risk of paradoxical agitation. Some patients actually get more agitated when you get benzodiazepine, which is obviously not there with Dex. And some benzodiazepines are notorious for precipitating delirium as well. So all these problems are not present with Dex. But when would you actually prefer benzodiazepines? One is the patient with seizures, because Dex doesn't have anti-epileptic properties. And if the patient is having very severe agitation, you're not at immediate threat to the self or to the staff, then you'll have to go for benzodiazepine, because dexmedetomidine will take a bit more time to actually act. Now, obviously, setting up an infusion and all in that kind of patient is not practical. And obviously, there'll be some problem with availability as well. It's not probably not available in every ED out there. It's more of an ICU level drug compared to an emergency level drug, emergency department drug. So this is one approach to the agitation in these patients. This is taken from the IBCC area. So if the patient is not having any agitation, you just have to follow the observe the patient, because if you stop the serotonergic medication, usually the patient will get better within about 24 hours. So if the patient is not having severe symptoms, you just have to wait and watch. With the patient is having mild agitation and the patient can take some oral medication, then you can try ciproheptadine. If the patient is having something more than mild agitation, then you will have to consider something else. Then you will look for any hard indication of a benzodiazepine, like profound agitation, or the patient is having seizures, in which is you go for benzodiazepine. Otherwise, you can go for dexmedetomidine, and you will start with an infusion. And once the patient is gets better with the infusion, then you can consider adding something like ciproheptadine as well. But this is probably not necessary. Oh, and overall, ciproheptadine is probably not that clinically useful drug for this disorder, because basically mild symptoms and of a self-resolving disorder. So it's not really that important. Coming to hyperthermia management, again, for important thing is antipyretics won't work, despite what some sources might tell you. Antipyretics are not what you should be relying on. You should be looking for physical cooling methods. Avoid physical restraints if possible, because that will again increase the risk of hypothermia and rhabdomyolysis. And you have to go for physical cooling methods. Hypertension. If a patient with this disorder is having hypertension, again, first don't treat the BP. First treat the patient's agitation. First treat the patient's pain if present. And again, while treating pain, don't give fentanyl, don't give tramadol. If the patient is still hypertensive after doing all this, then you can consider an NDG infusion. And keep in mind that you should not use something like hydralazine. Hydralazine, anyway, is not a very popular drug in the emergency department, but you should not use that, because that can also lead to increased serotonin levels. What are the indications for intubating these patients? So, besides the usual indications, some of them are severe chest wall rigidity in the end stages of this disorder can hamper ventilation. Severe agitation, not able to control at all, you might consider agitation. Profound hyperthermia. One of the best things for profound hyperthermia is actually intubating, paralyzing the patient. The patient's temperature will come down. That is one of the most rapid way of controlling the temperature. And obviously, in status epilepticus cases, you have to intubate the patient. Remember, avoid succinyl choline, avoid fentanyl. Succinyl choline, obviously, because of the risk of hyperkalemia, abdominal in these disorders. So, in summary, there are three things that I would want you to remember for differentiating NMS from serotonin syndrome. One is the drug history. So, serotonin syndrome, serotonergic drugs, NMS, D2 blockers. Second is the time course. Serotonin syndrome, very acute. NMS more of a subacute phenomenon. Neuromuscular features. That is the third thing. Hyperreflexia and clonus versus rigidity and more of a Parkinson's-like features. That is Parkinson's-like features favors more of NMS. So these are the three main differentiating factors between NMS and serotonin syndrome. So this was all about these two disorders. If anybody has anything to add or anything to ask, they can ask now. Otherwise, we'll be switching to another topic. Another very short topic, I promise you. It won't take that long.
So just one thing I would ask, have you ever seen a patient with this serotonin syndrome or NMS, and how did that particular patient present us? Was it like along the same lines? Was it a difficult diagnosis to make, or?
I have seen, I think, 4 or 5 cases of serotonin syndrome and 1 or 2 cases of NMS. By the NMS cases, I was not the first person to actually see them. By the time I saw them, the patient was already intubated. So once the patient becomes intubated, then it's like very difficult to actually assess for a lot of these things. So that is one thing. Serotonin syndrome, again, it was very classical. You'll get all of these findings. The angle clonus, the hyperreflexia, it will be more prominent on the lower limbs. Will have a drug history. Most of the time they'll be on multiple medication. They'll be on the some antidepressant. They'll be somebody must have given them MSAT. Somebody might have given them fentanyl. Somebody might have given them linezolid in an outside hospital or something. Then they will present to you with these features. So it is subtle. They'll be like sometimes they'll be presenting to you in the yellow area, and they'll be in the yellow area for a few days. Then they might develop these disorders. So it it is not. Sometimes it's obvious serotonin syndrome. Sometimes it's like very subtle, and it becomes difficult.
Right.
Sir, in case of serotonin syndrome, the main aim is to control the pain and agitation. So, if we can't use fentanyl and tramadol, what else can we use?
You can the other opioids are safe, so you can use other opioids. It's specific. It's not a class of it. It's specific to these two drugs. Actually.
Oh, okay. Benzodiazepines only if seizures are there, then.
Yeah, if the patient is having seizure, then you will have to give an anti-seizure medication and you will have to give benzos. Otherwise, if the patient is having severe agitation that you have to control it right, and then again you'll have to go for benzos. Because it's like there's like this Goldilocks patient who is actually appropriate for giving Dex. So it's like the patient is having something more than mild sedation, but the patient is like, it's not like the patient that you're saying like okay, this patient I need to intubate now. That is not the patient that you'll go for a Dex or something. So
okay.
Again, Dex is not like per se available in our ADS.
No, it's not available. Okay, so